Hi everyone, my name is Gregory. Today I would like to present a simple case where the root canal failed on tooth number 19 and we placed the implant and Emax crown. This patient came to my office in 2006. He's a physician running a busy medical office, doesn't have enough time. Came with periapical abscess on tooth number 19. You can see both canal failed, big and huge translucency here, PEP. Referred him to root canal specialist and the dentist, where the root canal was redone, and you can see the infection be contained, and the patient was fine. Placed the final restoration, the new crown, and came back to me in 2010 with a tense pain, special and biting, and vertical fracture was diagnosed, and the tooth was hopeless. So the socket preservation technique procedure been offered to the patient, and have been placed the bone grafting. So how I do the extraction special on the molars? I dissect those mesial and distal roots separately so I can extract without damaging the surrounding bone, and I place the cancellous bone right into the socket. So there is a different topic of discussion being raised. It's what kind of bone grafting I placed, what material, and again, the different dentist has different choices and preferences. What I usually use a cancellous bone if my all walls are intact. So my first the procedure is I extract the tooth, take my perio probe, check all the areas, make sure that all the walls are intact, and if 5 walls are intact, the bone supply is usually great. It doesn't matter what kind of material you usually place, it depends what you're using after when you place the bone graft. So I don't use the most expensive material. There is no actual magic bone graft to use in this kind of situation, but again, it's I put a cancellous bone by ACE or by Pures, and fill the material and wait 3 months until I start putting the implant. But once again, it's if you don't have any 3D X-ray, what I usually do is measure with a perio probe my length, my width, so I know approximately what kind of implant I'm going to place in the future, so I have a little bit like a guideline for myself. Again, in 3 months the patient come back, I numb the patient and use again the perio probe and try to probe the area to see what quality of the bone graft I have, and what my sequence of drilling would be. So in this case, you can see the number 19, the roots are shorter than the rest of the teeth. I'm not trying to place deeper implant right here. I'm not trying to place more than 10 millimeters, but in this case it was 11.5 by 6 millimeter MIS implant. My sequence is trying to put a pilot drill. It's make sure it's I'm all right with occlusal surfaces with the upper teeth, and make sure it's right in the middle between the surrounding teeth, so make sure I put less leverage on my restorative parts, so to make sure I don't have any screw loosening and other breaking parts of the restorative parts. And when the implant been placed, I usually condense the bone if it's not. Usually if it's type 4 bone, it's trying not to use the final drill all the way in right here, and with the screws, with the threads of the implants, I'm trying to condense the bone to improve the quality of the bone on socket preservation side. So I wait usually 3 months, and in this case you can see I've been doing the first and second stage of the surgery at the same time. I put a healing cap right here on top of it, and patient came back. It's and I usually, in most of my cases, I do custom abutments, but I want to show you how the surgical part went in. So you can see here that's how my bone graft been integrated, been placed. What I do here, it's you can see it's integrated. It's integrated with the cortical bone around this area, and make sure I will not perforate any kind of walls surrounding the implant. And usually for my safety technique, clinical issues, I usually put my periosteal elevator right up to here. If I drill and accidentally perforate my lingual wall, that's I will fill with my periosteal elevator and make sure it will not damage surrounding soft tissue. Again, you can use a little bit longer, smaller implant, but I'd rather probably use a bigger size implant, a little bit shorter, but have better stability than the rest of the side of the implants. Again, it's when we're done with the implant, again, it's a place custom abutment right here, and again, make sure it's right at the center, and make sure I have enough clearance and support of the restorative part. The clinical hint, for example, for the front area when we use custom abutment, depends how much soft tissue thickness I have on the facial. Sometimes we buckle a place in the front area. I'm trying to do my custom abutment straight, and where I have to have my say the soft tissue area to be developed on the front area, and then I put a little bit a flare on my implant abutment. So in this case, again, it's I usually place the margins above the gum, so make sure I can clean the area and I can see the interface. But again, in the front area, of course, I will probably do submerged into the into the tissue. But at the back teeth, it's usually do a 0.5 millimeter a little bit down to soft tissue or at the level of the free gingival area. You can see this final product, the Emax crown been designed. You can see the interface between the implant abutment and the crown itself. You can see that also there's a crown being placed right perfectly right in the middle, perfect occlusion, patient is happy, and you can see here that there is no voids, perfect emergency profile, and again it's we gain probably the good result in this case. Thank you very much.